Hi, I'm Greg Schroeder from the Rothman Institute, and we're going to discuss the best treatment for cervical myelopathy, anterior versus posterior, and what makes us make those decisions today. I'm here with a great panel of experts.
My name is Scott Blumenthal, and I'm an orthopedic spine surgeon at the Center for Disc Replacement at Texas Back Institute, so you've already heard my bias for cervical disc disease.
Well, my name is Rolando Garcia. I'm an orthopedic spine surgeon in Miami, Florida. And thank you for having me here.
All right, so when we talk about cervical myelopathy, obviously we're talking about compression on the spinal cord, and there's lots of different reasons that you can have compression on the spinal cord. So when you look at it, what are, in your guys' opinions, the reason to absolutely do something from the front?
It's interesting. I think most of the myelopathy that we see in the U.S. is early stage because patients come to the doctor sooner here. Right. When I did some work in China, the patients with myelopathy had myelopathy like I'd never seen before. Mm-hmm. So we see someone with axial neck pain, some radiculopathy, and a few pathological reflexes. We call that myelopathy. I tend to see, those are most of the ones I see, and if they're 1 or 2 level, I do them from the front. My bias, unless they've got too much degeneration or deformity, is to preserve the motion with disc replacement. But certainly 1 and 2 level, front, 3 level, bubble, 4 level, probably posterior, or significant deformity.
Yeah, first of all, I think that is a great question. The absolute indication going anteriorly, I like to treat where the disease is located. So there are circumstances in which the disease is definitely anterior. Mm-hmm. There is issue with the sagittal alignment, and obviously the multiple levels is another factors. There's multiple other additional factors, but primarily I treat the cause of the compression, the cause of the disease. And if that happens to be anteriorly, then that would be my primary indication.
Unless it's OPLL.
Yeah, I was going to say, so let me be
Yes, it's OPLL.
Yeah.
So if it's OPLL, though, even though the primary compression is in the front, you go from the back, or you still,
yes.
You do go from the back?
Yes.
What about you? Do you still go from the back for OPLL?
I think that when you go on the risk-reward ratio, the risk of going from the front with OPLL is so high, and we've got a growing Asian population in North Texas, so we're starting to see a lot more OPLL. Mm-hmm. So yeah, those pretty much from behind.
What about the patient who comes in? Sagittal alignment is okay, for the sake of things. A 60-year-old male, significant myelopathy, fine. He's got 5'6" and 6'7", but he's also got retrovertebral issues. Is that something where you say, listen, I'm going to do a 1-level corpectomy, or is that one where you would then say, all right, listen, rather than doing a corpectomy, I think I'm going to do something from the back?
Good point, and I see myself increasingly getting CT scans, regardless of whether they come in with MRIs to assess that very issue. I think in terms of addressing any type of bony ridge, bony osteophyte, I think that I see myself being more aggressive in terms of going with a corpectomy, mm-hmm. plus the fact that I think that now with some of the tools that we have available to us, we're able to do a much better job of addressing sagittal alignment when we are able to do that. Of course, that brings the issue that in some of these cases, regardless of how much we try to avoid it, we have to go not just in the front or in the back, but on both sides.
Right.
Yeah, I tend, it's very interesting that you bring it up at a timely point, because I was talking with the fellows, and they were asking about corpectomies. And I said, I can't remember the last time that I've needed to do a corpectomy, since most cervical disease is at the disc level. Well, the next patient walks in the clinic, has a herniation behind it was either C7 or T1 body, where you can't tell which disc it came from. Yep. There's no way you're going to be able to get that without doing a corpectomy. So, like I tell the fellows, you can't be a one-trick pony. You got to address the patient's pathology on an individualized basis.
I'd like to get the point of view of both of you. At what point in terms of anterior decompression do you feel that you're compelled to go in the back and address things as well in terms of stability? 1-level corpectomy, 2-level corpectomy.
So this is an interesting topic because we have very differing opinions at the Rothman Institute. Okay, so from my standpoint, anytime I do more than a 3-level ACDF, so if I do a 4-level ACDF, they get a 4-level ACDF uninstrumented in the front, and then screws in the back. Dr. Hillebrand, on the other hand, will do a 4-level ACDF that is a standalone 4-level ACDF. We presented the data at NASS last year on kind of his series of patients for this. And in general, through a couple years, they all have non-unions, but so what? They all do very, very well. So I think so
you should be using metal cages so you can't tell if they have a non-union. Just follow them clinically.
So I think the question is really challenging, because when we look back at pseudarthrosis and do pseudarthroses matter, I think before we were doing plates, it was clearly a problem, or cages, if they had a significant pseudarthrosis. But now, maybe over 10 years, those people will turn out to have a problem. But other than that, right now it's not in the short term. When we look at corpectomies, so again, I think from my standpoint, if I do more than a 1-level corpectomy, the patient is getting something in the back. I mean, that's just, I don't feel comfortable doing it. But the literature that we published from our institution said, realistically, up to 2-level corpectomies you can do, and they do pretty well without instrumentation in the back. Once you get to more than 2 levels, then it becomes a huge problem. So we, again, Dr. Hillebrand will sometimes do a 2-level corpectomy without doing something in the back, where myself and some of the other guys, every time you get more than 1 level, you're getting screws in the back.
I think it's a great question. And the two trends that I see, and it's perhaps even more prominent in the lumbar, but in the cervical, is we're doing DEXA scans on these patients. And if they've got sufficient bone quality, I think a multi-level anterior construct will hold up just fine. The other thing I'm seeing more and more in our practice are the quote-unquote standalone or integrated cages, the cages that also have the screws in the front. And that biomechanically seems to be as sound as allograft and a plate, but perhaps may have less retropharyngeal issues, swallowing difficulties, things like that.
So are you using those on a regular basis?
Personally, yes.
Okay.
And I'd say, of the surgeons at Texas back, probably a third do, and probably 2/3 are still doing peak cages and plates.
So I think, I don't think in the last 4 years I've seen a single one of them done at Jefferson. So we don't, for the most part, we don't do any of them. We don't even do cages. We are still allograft, local autograft, and a plate.
One thing that I wanted to cover briefly is I have a personal bias that if someone comes in with cervical myelopathy, I decide to go posteriorly, and they have a fair amount of neck pain, my procedure remains a laminectomy and fusion. When do you integrate laminoplasty on those patients?
For the most part, so the fellows at Jefferson call it the Jefferson Special. We do a C3 to C6 decompression with usually a dome of C7 and a C3 to T1 fusion. We usually do lateral mass screws up through 6 and then pedicle screws at 7 and 1. That is the vast majority of the time. That is my answer. I think I've done a laminoplasty once in the last probably 8 months, 9 months. That was really just me. The patient came in and they were a perfect candidate, right? They didn't have neck pain. They had no radicular symptoms. It was a pure myelopathy, and it was multi-level. And from my standpoint, maybe this isn't true or not, I don't even do it for OPLL, because I'm concerned with OPLL that if you have that micro motion, then the OPLL can get worse. So instead, for OPLL, I think that's a clear indication to me to fuse it to stop the OPLL.
Yeah, I think it's very training dependent. We've got a couple young surgeons in our practice that trained in a fellowship. They did a lot of laminoplasties, and they've got their, quote unquote special. But I think the older surgeons tend to do more like you described, is screws and wide laminectomy.